We've got a couple of items now which Arlene is going to lead us through. I don't think she'll be the only one talking through this. We've got the draft mental health strategy, and I think it very much is draft, and this is our opportunity to play into that, not just today, but I'm sure Arlene will invite us to make comments following the meeting. And then we're going to move into the Highland drug and alcohol recovery services and delivery, which I think is linked with it. So we've got really two items here, which I've been looking forward to for a number of meetings to actually have a discussion about. So I'm really just going to hand over to Arlene, and she'll take us through the draft mental health strategy. And we'll pause for some discussion, and then we'll move straight into the Highland drug and alcohol recovery services delivery paper as well. So over to you, Arlene.
Thank you very much. Okay, I'm going to share a very short presentation just outlining the strategy. So like Pam, can you let me know if you can see it, and is it going into actual proper thing it's supposed to do?
Yes, it has.
Excellent, thank you very much. Okay, so like Jerry says, I'm absolutely delighted to be here with our draft strategy. It feels like I've been talking about this strategy for years, actually, and it probably has been quite a long time in the coming. And we've promised it as well for a number of months to the committee. So this is our draft strategy. What we're looking at and providing you here is what is our most up-to-date version, if you like, but we've not taken this out for consultation. We have an event tomorrow with what the newly formed Mental Health and Learning Disability Strategic Partnership Group, where we will kind of share it with those people there, and we will hear their feedback and look to make changes from that point. But we are very keen to hear your feedback. So the up to this point, we've done, well, and the team have done 76 conversation cafes and network engagement events in order to get to the point of having a strategy. And that included some really innovative stuff like going out with the street pastors and chatting with providers and other people over cups of coffee to hear what people wanted from a strategy and what was important to them about the mental health and learning disability services. We were really clear, although it was very hard to stick to the scope, that this was about mental health and learning disability services, that the workaround about mental wellbeing sat in a different strategy. And although the edges are all very wavy, we were trying to be clear within our service strategy what it is what we wanted to achieve. Obviously, this strategy sits underneath Together We Care and the Adult Strategic Plan, which is currently out for consultation. So we really had those things in mind as well. We also sit within a newly launched Scottish Government mental health and wellbeing strategy, coming home reports, MAT standards that you'll hear about from drug and alcohol recovery services in a moment from Teresa. But so there's a vast array of strategies that tell us what we need to do. And so when we went out, what we were picking up from what we were hearing is that actually there's lots of people who've got lots of different views about what services should be delivered. And what we're saying is actually we've got a lot of guidance about what services should be delivered. But what came across loud and clear was there's a really clear vision of about how those services should be delivered, and actually we've never articulated the how. And the statement that we've got there about that relationships are so important, good care can't exist without good relationships, that came from one of the events, and it was one of those ones that actually just it kind of struck right to the heart of you of this is what we do and this is why we do it. And I would like to say that it's never more important about relationships than within mental health and learning disability services. Nothing we do can be done without a good relationship with a person. So we're not like surgeons or dentists who doesn't really matter what you think of the individual or what the relationship you have. You can go in and fix their teeth. You can't do that in mental health and learning disability services. So we've pulled that into the absolute heart of what our strategy is. We've created a strategy then that is based on the how are we going to do it. And what we've got is 5 commitments. And we've taken that from a service design guidance, I guess, around about what should services look like, what should good services look like, not necessarily good health services, but good any services. And I think that's really important because actually people are consumers and they have expectations about what services should be like. And I can order a book on Amazon and it'll be at my front door in the next day, and it can take me literally seconds. And yet actually to get into our services requires a very long drawn out route of referrals, etc. So we looked at those, what makes good services, and then how do we put that into the services that we've got. We are going to do that. We've created the 3 C's, and we've got that little kind of Venn diagram or whatever it is you call it, that we will deliver our services compassionately, collaboratively and consistently, and we will have these 5 commitments. The strategic partnership group, which I referred to a minute ago, that's been established now and is meeting for the first time tomorrow. It's a 50-50 split. 50% of the people in the room will be NHS staff who deliver services, and the other 50% will be our partners. And I'm really keen that that's the weighting that we have, because we have got to deliver this together. We cannot deliver health and social care on our own any longer, and we really must strengthen that. And that goes back into what Pam was saying earlier about strategic commissioning and us working with partners and community planning, etc. The next step is, once we've got this kind of as a ratified, people have nodded their heads, said that they think it's a great idea, is that we will come up with what the commitment service plans are. So what do these commitments actually mean to the services? And so that is, for example, with mental health, adult mental health services, that would be about services for people who are in crisis and are urgent and unscheduled care, because that's what we heard was really important. Within learning disability services, it's about enabling people to live independently. So the very different strategic intent, if you like, around about each of these services, but they will fit within the framework of our commitments. We will also have, underpinning all of that, our transformation plans, which we currently have already in place, which links with our finance plans. We're working on workforce plans alongside the Scottish Government. We will be creating strategic commissioning plans, which will all underpin, so that plans will sit underneath the strategy. I'm going to come out there now. I should be able to exit, I think, and stop sharing. So you've all have a copy of the draft strategy within your papers, and we are very open to any kind of comments, feedback, whatever anybody would like to say about it. We've fixed one typo. The word "from" is missing in the overarching in the second commitment, and for the life of us I don't think we can work out how to get it back in. This document will it'll go to medical illustrations. So this is the version we've created on Visio, and Ellie and our team have done a pretty cracking job of doing that, but it will go to medical illustrations. They like it when you're absolutely certain you're going to make no more changes, and they make it proper, pretty and corporate and so on. Well, really welcome people's initial feedback from it, and then also happy to meet with individuals if they want to go into more detail, or you can email me with your comments, etc. However you would like to contribute.
Arlene, thank you very much indeed for that. I'm just going to throw it straight open to folk, because I can see some hands going up straight away. Kay?
Yeah, it was just to come. Obviously, working in the industry for like 30 odd years, it's the relationships is very important, but that comes back to sort of staffing and how you support staff and maintain staff, because you can know somebody for 20 years and just having the rapport of the little things that they do or whatever is really important to that person, especially if they don't have family around them. And the other point I want to make about is living independently. Is that the top goal, or living with family, or living near family, or there's other things that people might want other than living in a house by themselves. I know that it's a lot of people do want to live in the house by themselves, but is that right for everybody? What about living with their family, and things?
Arlene, just come back in.
Yeah. So I guess what it's all about the phrasing, isn't it? And about the language case. So by living independently, it's about people living as independent lives as possible. It doesn't necessarily mean living in your own house. And the top thing that ever comes out when we do any consultation with people with learning disabilities is about employment. People want a job. People want to have a job and be the same as other people, as what always comes out from that part of it. But what we see is that we will work with people in order to create what the plans are that sit underneath the commitments that are directly relevant to them. So those were just some examples of what we're expecting to see coming out as the change ideas, so kind of picking up with some of the language that the children's services colleagues were using that will sit underneath the commitments of how we deliver our services.
Kay, did you want to come back in there?
Yeah, it was just about the people having a job thing, because you know, yes, I think everybody who is able to have a job should have a job and have that life experience. And I mean, I've been supporting people into employment for about 20 odd years, so you know, it's really good when they get that satisfaction. But we have to be realistic as to how many people are going to have that experience, you know, and are capable of having that experience. I mean, within the 20 years, yes, I've supported lots of people in work placements and one thing and another, but they very, very rarely last. Sometimes they do, and that's absolutely brilliant. And it's you know, I'm not saying don't try, because they don't last, but it's the reality. And there's the reality that there is an awful lot of people for that is not an option, you know. So it's to focus on these people and not taking into account these people. It's not really very fair to all these people, you know.
Arlene?
Yeah, and I would certainly hope that isn't what we are attempting to do at all. And I think the work that we do with people with very complex needs is kind of, and I think from earlier what we're saying is that, you know, that the funding that we invest in people with very complex needs. But I think what we're saying, I guess, from the point of view of the strategy, is that, you know, number 3 is about our services work together with you, and that's very much about being person-centred. It's about being person-led. It's about understanding what each individual wants, whichever part of our mental health and learning disability services people come under.
Muriel?
Thank you. Slow to get to the mouse today. Thanks, Arlene. As ever, there's so many strands to this and where various things. So it's just a couple of questions that I want to ask, which it's the living independently. I fully understand that, but I think we need to, well, would it help if we started using the term enabling to live independently? Because we talk about enablement so much, that where does this sit in that strand? The other thing you mentioned briefly was the alcohol, and in light of I think it was yesterday, the data that's come out from that, are we having to change or review where we are? Because the Highlands is sitting in a not a great position, really, and do we have to sort of remobilise some forces towards that?
So I think that probably links best to the next paper around about drug and alcohol recovery services, and Teresa will kind of present about where we are in the assurance report around that. So that will link in there. And I guess what we were trying to do, because it's a mental health and learning disabilities services strategy, and so I think my 2 examples have probably taken you down that sort of rabbit holes almost in some respect, because what we're trying to do is create an overarching strategy, which is really difficult when we work with people with such differing needs. And I think that's what I was trying to say, is that that's why we went down a principle-based strategy around about how are we going to deliver it. So we'll have the same commitments for every service going forward. What that will look like on the ground will be different in each service, because the individual needs are different within there. And I think it's showing the great array of services that we have within the mental health and learning disability services is fabulous. It's testament to the work that we do, and I guess it's what makes the job interesting, but it can make it really difficult when you're trying to box it up very neatly into one place.
That's great. Thanks, Arlene. I can find a rabbit hole anywhere.
Anne?
So, Arlene, there's so much to applaud in this document in terms of the process that you went through to get to this stage, and I'm amazed to hear that you're going to spruce it up even more, because compared to a lot of documents I see, it was incredibly readable and, you know, very straightforward. So I think, and the principles are fantastic. You know, nobody could well, I would hope nobody could disagree with them. They set out a really ambitious set of well, I think it's really ambitious in terms of the type of service that this is seeking to provide in collaboration with partners and with our services. I suppose, and I mean, it's really helpful to see these next steps and how you see this, I suppose, being operationalised. I guess I do have a bit of a concern in terms of, well, I suppose what I should say is, how do you see this helping our services to produce their own, can't remember what you call them, sorry, commitment plans, was it, or service plans, given the kind of challenges that we know exist and we hear about in the committee in terms of our waiting list situation in a number of services, your vacancy list. I know from a lot of what I read, not just in this committee but elsewhere, just how much your own staff are dealing with in terms of the pressures that they're under. And we've talked in the past about some of the changes that we want to make within the service in terms of shifting towards a more community orientated provision and things like that. And so I'm conscious of the substantial agenda that the services that you've outlined here face in the current context. And I guess that that was a bit of a concern for me in terms of how ambitious this document actually is, which is great, but I'm just wondering how you see these individual services that are under so much pressure being able to work with this document to come up with achievable commissioning strategies and service plans.
Yeah, and I think that's a very fair reflection of what kind of day-to-day life as an operational manager in the NHS is at the moment, regardless of which service you're working in. But I think what we're hoping is that this is an enabler and what we can use it as a mirror to go back to help us prioritise what needs to be done. And not then when we are developing services or changing services or reviewing our services, we can look at it from the lens of, is this important? Is this important to the people that we work with? Or is this one of the things that we've always done and actually no one can quite remember why we've always done it, but we've always done it and it would be too hard to take it away because a group of people may very well get kind of very distressed about that. But actually, if we can look at this as a framework to do that, and I think we also see it as a way of it's not rewarding staff, but it's supporting staff and supporting their role within the service. So for the operational managers, they create the plans, but for those folk on the ground, of which there's way more than there are of APRIL managers, that this will remind them that what they do every day is really important to us and how they do it every day is really important to us. And so what we're hoping is that actually also adds to the resilience in that we are seeing that that's important as we go through what these major changes are. So, and I think that the commitment that we've made to work in partnership with our partners will also enable us going forward, because that will help us to create different parts of the service where someone else is delivering it rather than it necessarily being within our NHS traditional ways of doing it. The proof will be in the pudding, though. You're absolutely right. It's a strategy. You can have a very nice document that says all these things. What are you actually going to do next? And that was a real struggle for us as we came through of do we fill this with lots of whats or do we do it with the hows? And the consistent message that we got was the how, and that's why we went there. But the next step absolutely is the plans of what are we going to do and how are we going to change it. But what I'd like to be, what I am assured about is that we can change it within a framework of it's the people that are important in amongst all of this as to how we do it. So maybe still ambitious, but we'll give it a shot.
Is that okay, Anne?
Yep.
Okay, Joe.
Yeah, thanks. And I agree with that, and I think the document's incredibly readable, which is great. And I love the approach of taking principle-based strategy rather than the what. I think that's a really potentially powerful approach to take in terms of service planning. I had two, I guess, one very specific reflection, which will be completely anticipated given my role, and the other, which is more just a reflection, and I think about probably more than just this strategy actually, but thinking about some of our transformation work. So my very specific thing is around your commitment for and high quality services, and there's reference in there to role transformation, but I would really like to see a reference to the new workforce planning standards coming out of Scottish Government, and the fact that there's a commitment to that being a multidisciplinary approach to service delivery. I think, and my other one is about, so if you take a principle-based approach to service planning, I'm wondering what assumptions we've already made about the delineation of services and whether that is constraining our ability to transform. So you've got your principles, but then you've said in this bit of the service we're going to do that, and this other bit of the service we're going to do that, and this, and I'm wondering, I guess, if that constrains our ability to transform what's the spaces in the middle. So how do people move from adult mental health services to older adult mental health services? What's the space for people with an addiction and potentially a functional mental health problem? How do we get creative about the resource that we've got? And we've talked at length today around the constraints of resources across all community services. And I think I'm just a wee bit concerned that having that delineated as a service plan that applies the principles potentially loses some of the power of taking that principle-based approach to design.
Yeah, and I think it's probably something we could debate all day, Joan, about the how do you do it and how do you create a strategy in order to do that so that you don't lose that. And the opposite argument is if you make it too generic, then you can't get specific enough, and then people don't know what it is they actually should be doing, and therefore they haven't got the guidance around it. So, but I agree, and I think I talk lots about the wavy edges, and it's the same between mental health and wellbeing as well as between our services. And you shouldn't be ever, you only sit. Dars, Teresa will talk about that later, but that you can't. What if you have a learning disability and a mental health condition and you're old? And you also have some kind of issue around about drug and alcohol recovery services. You sit in all of those services, but how do we make that ease between them so that you're not siloed in there and around? How do we do that? And I think in some respects, because we sit in one division as a mental health and learning disability division, the senior leadership team, for example, we meet weekly, more than once a week, and we have lots of shared clinical governance, for example, is shared. We have lots of shared spaces where we take forward these plans, so we all are aware of each other's spaces, which allows us opportunity to comment on each other's plans and therefore help put that in. But I think that's a fair point, and I think we probably need to strengthen that within the strategy to make sure that it's clear.
Apologies everyone there, the internet a couple of minutes of discussion. I'm not seeing any more hands up. So Arlene, just fill us in. What's the next steps in terms of? I was thinking of that awful formality of strategies getting approved and all of that. So it's maybe yourself or Pam to pick that up. And how might committee members contact you? I suspect it's just email to feed in any more comments or discussions that they might want to have.
Yeah, so I think, and Pam can kind of keep me right on this, but so tomorrow we've got the strategic partnership group where we will take it to the group and we will have a conversation about does it feel right, and then also what do you think is going to look like, what are your change ideas for going forward. That will give us the assurance that we've got this mostly right, and I think we've had some really positive feedback here today, which means we'll get it to medical illustrations to make it look even prettier than it already is. And then Pam, I assume from there it goes to the board and then we can roll it out. We did lots of engagement beforehand. I think it then just goes to the board. Is that right, Pam?
Yeah, we just need to just double check that we've done all of our public engagement, and have we done an equality impact assessment around that, and that would be the bit that would qualify us and direct us about any other groups or individuals that we need to engage with, and then on that basis we could conclude that we followed our participation and engagement framework and get that signed off.
Thank you very much, Pam. So I think in the interest of time, again, we could talk about this, but what we would do is we would note for the minute, Stephen, that we've received the draft strategy, we've discussed it, made some comments. We've asked members to contact Arlene if there's any other areas they'd like to have a discussion about. And we look forward and welcome the progression of the draft strategy through the formal board approval process. Thank you very much, Arlene. So we'll move swiftly onto the Highland Drug and Alcohol Recovery Services, and you think we had almost planned this because we've had a couple of national reports issued recently, which Muriel has obviously mentioned, but and I think it's important that we refer to those. But I'll hand over to yourself, Arlene, and Teresa, who I think are going to take us through this.
Yep, thank you, Chair. So I will pass to Teresa, who is the service manager for Drug and Alcohol Recovery Services. So she's got other bits of title on the end of her, but for today, Drug and Alcohol Recovery Services there. So I'll pass to you, Teresa.
Thank you, Arlene, and thanks for sparing me having to say the whole title. A big thank you. I've never come to the Highland Health and Social Care Committee before, so I appreciate the opportunity to come and speak to this paper. As I said, Arlene says my name's Teresa. I have just come back to Highland, and it's been interesting to listen to the dialogue until now, where there's Anne referred to a substantial agenda, and Muriel, you're like, well, it mentioned the recent publication of the alcohol deaths, and actually what an opportunity, and there's a real need to make a difference, and I think we absolutely need a substantial agenda. There's no getting away from it, because the Highland position, our drug deaths figures came out last week, and we had our alcohol figures yesterday, which was 66 people died in Highland in 2022. That hasn't been included in this paper purely because I didn't have that information, but I'm hoping I can give you some assurance as we speak to the paper in general of some of the actions that's planned. I've given myself a couple of slides just to keep myself on track, but I'm going on the assumption that everybody's seen the paper, and I welcome any to pick up any bits once I've just kind of run through a couple of slides. Let me see, I think, where's it gone? Presentation. I'm not, just give me a wee second. It's on my other screen, but for some reason, I don't know what's happened. And screen, windows. Right, okay, I found one here. Hopefully this will come up. Am I sharing? Yes, I'm assuming I am. Thank goodness. So yeah, this is all in your paper, so you'll already have seen it. But I suppose just to kind of summarise, you may or may not have heard of the medication assisted treatment standards, which is commonly referred to as MAT. I think since that was introduced nationally in 2021, and Highland has been beavering away in the background, developing plans in order to implement these MAT standards. I'm going to talk about them more in my next slide a bit, just some of the sort of context of why the MAT standards came about. But really, the long and short of it is where we are just now, is that the work we've done to date in trying to implement these MAT standards has been done right across the service. We're a specialist drug and alcohol recovery service, and it's not just about drug deaths, it's about alcohol deaths, it's about everybody who's referring to the specialist service. And you can see from that slide that I'm shared, actually probably about around about two-thirds of people who come into service have got an alcohol component, so we cannot lose sight. These people, their needs are paramount, just as reducing drug deaths. We want to reduce harm from alcohol as well. And Highland has kind of got off to a slow start, but you'll see again, great news. I mean, from the first time I've seen in a long time, in the last quarter reporting, we started achieving the national standard. So the national treatment standard is that nobody should wait longer than 3 weeks from being referred into service to actually start that treatment. Now, this is a huge achievement for us. If you look at us 12 months ago, we weren't. So we've had a 20% improvement. We're gradually building into interventions and new ways of working, and we're getting to where we need to be. But we're a long way yet of where we need to get to, because we're still having people die or suffering harm as a consequence of alcohol or drug use. So that's just a bit about that slide. Let me just see if we can push it on and talk a bit about the MAT standards. I'm kind of going to come on the assumption that a lot of people won't know what the MAT standards are. I've been living and breathing it for the past year, so I kind of think, oh, everybody knows about this, but they don't. So the MAT standards really is in the context of, there was the National Mission for Drugs, and they looked at year on year, Scotland's people dying from drugs, drug-related deaths was increasing year on year, to the point that we're actually one of the highest places in the world that have drug deaths, and this wasn't showing any sign of slowing down. So in order to try and address this pandemic that was happening, they had to look at, well, what wasn't right in services, what were people dying, what was that telling us, and that's come up with these 10 sort of evidence-based standards of what we need to do and what we need to do at pace. These are national standards. They're being implemented at the same pace across the whole of Scotland in an attempt to reduce drug deaths across Scotland. The national data that came out last week showed that there has been a decrease in Scotland. Unfortunately, in Highland, we've shown a bit of an increase. There was 7 deaths, as was compared to 7 deaths in addition to what was the year previous, 42 recorded, and it had been 35 the previous year. But I'll talk about a wee bit more about that later on. But these standards are here. They're not rocket science, you know. Why do we need people to access treatment on the day that they present? Well, you miss that opportunity. You know, if you don't catch people there and then, they're off and further down that decline. If you had seen, this is our sort of national benchmarking RAG status that was done in June, and I think compared to a year ago, we've made a significant amount of progress. I think if you looked at this a year ago, it was probably red all the way down. So I think in a really short space of time, the services have turned things around quite significantly. And that's been from really different playing fields. I think there was something talked about, you know, things are different in different areas and services being de-aligned. But this MAT standards is right across Highland. So, you know, it doesn't matter whether you're in Fort William, you're in Inverness, or you're in Lochinver. These are the outcomes we expect for everybody accessing specialist drug and alcohol services. I'm not going to labour too much about it. You'll see the red ones. The first 5, there was an expectation that we would have implemented by April 2023. We're still amber on a couple, but we're making good progress. The 6 to 10, they expected to be in place by April next year. Now, the reds there are particularly in the relation to psychological therapies, psychological interventions. The red's about what's the interface between drug and alcohol services and general mental health services. We know, and I'm sure you've all heard stories about people ping-ponging between services. You know, they present to mental health, and mental health's like, oh, no service for you, you're drinking. And drug and alcohol services is saying, well, actually, you don't want to address your drinking. And we're leaving people vulnerable and unsafe in the community with our current pathways. So it's great that the MAT standards is saying you need to address that, and we've made really good progress in starting to look at that. We've got steering groups in place for the sort of the interface between generic adult mental health services and drug and alcohol services and primary care, to make sure that that seamless service is there for anybody who presents to service, and each service is clear of its responsibilities. The initial meetings were a bit fraught, but actually we've got a good framework now that we can underpin taking that work forward, and I'm quite confident we'll get there, because the good thing is we've got the solutions within us. You know, mental health, we're all mental health, we're all drug and alcohol. It's up to us to find a solution, so I'm quite confident that going forward that's not going to be so much an issue. The other reds that we've got there is about a psychological interventions and actually providing psychological trauma-informed care. They're a bit more challenging. We've heard other places say about their estates. You know, some of our accommodation across Highland isn't that great. We don't have a lot of space. We don't have, rooms to deliver therapy in some areas. But that is, again, been picked up within a steering group. The same with our psychological interventions. We're looking at, we've recruited and we've increased our psychological expertise within the service, and we're looking at, we've got a steering group in place and an implementation group in place to make sure that at the point of MAT, people can receive appropriate psychological care as well as medical treatment as well. And the good thing is, although this is MAT and it's to reduce drug-related deaths, we are using this for anybody that presents into service. So if you're presenting for alcohol and you're requiring psychological interventions, we plan to, there'll be parity in approach. Some of the work, just going into the sort of drug-related death element and the recent figures, there's some areas where we're actually leading the way nationally, and although it's very much in infancy stages, we've done a lot of work with custody and prison healthcare. When we look at the data of people who died in NHS Highland over a 3-year period, that data is telling us that 26% of those people were in custody or prison within 6 months prior to their death. So what an opportunity. If we can get people at that point, provide them with harm reduction, get people into service, there's an opportunity to make a difference and reduce harm. And this is just some of the early work that's been done to date. The teams are using quality improvement. They're measuring, testing, PDSAs, and refining their approach. We're already seeing a big increase in naloxone being offered. We're seeing increases in people being referred to outreach services, and we're seeing BBV testing increases. What we want to see then is, have they been taken up, and what's the difference? How does that impact on outcomes? So that's in your paper. And just really to just finish off, really, because that's not all we're doing. There's lots. I think, 42 deaths, and this is the drug deaths, view it that everyone was preventable, but also just to highlight that not every death has been related to the service that person has received. Looking at that data, that 3-year data, we can see that only 29% of clients were in service. So what's that about? How do we get into service? What's that data telling us? So what we're planning to do is work with our ADP colleagues and do a real deep dive in a workshop with partners to look for the themes and look for the opportunities to intervene to reduce harm. If we can get this, not if, when we get this, these robust pathways in for MAT 6, for MAT 9, for MAT 10, and we're addressing people's psychological needs and mental health, then we know that we will reduce harm. Again, that data from that 3-year period that they've looked at, that 71% were known to have a mental health condition. So we need to look at how do we get these people into service? There's lots happening. I'm not going to go through each thing, but I'm quite happy to discuss it in more detail. But yeah, it's an exciting place to be in. There's never been more a need to get this right. And on that basis, that's probably that's the reasons why I've come and asked for, give you moderate assurance to consider, because there is a lot working. What would make it substantial? And I think it would be, if we get to that MAT 6, 10 and 7, that we would be reaching a substantial assurance. I just want to highlight as well the financial overspend, which there's more detail in this paper. And I'll probably stop there. Thank you.
Teresa, thank you very much indeed for that. A lot in that, and a lot in the report. And again, we've had many items like this today where I think we could sit and talk here for hours about the way forward. But I think what we've got to recognise straight away, and I would hopefully you will take back to the team just to recognise that improvement from March 20 through to March 23. I mean, it's an enormous step forward, and I think you're right. And to set myself that challenge of what would give us substantial assurance, I think is really heartening to hear as well. So I think we've got a really positive news story here. I was going to ask you the question: how many of the, I can't remember if it was the drug deaths or the alcohol deaths were actually known to the service. So it is always an interesting one, isn't it? The people were not aware of, and it ties into your point about missing that opportunity on day one to get them engaged. This is where we come through. But I'll open it up to committee members for questions, observations, and comments. Muriel.
Yeah, just very briefly, and thanks, Teresa. That was really well presented and really great data, or not so great as the case may be. My concern is rural and targeting. I know we focus a lot on the Inverness area and some of the great work that's going on there, but how do we really reach the rural, particularly older women in our rural communities that are getting behind the wheels of cars and things like that? So how do we get in there?
Yeah, again, early doors, we're looking at this data, we're breaking down this data, but there is a recognition that local issues are different in different areas, and I think some of our data is really clear. You know, most of the drug-related deaths are happening in Inverness per head of the population, but you're right, there's other issues in rural areas, people driving under the influence, or whatever those issues will be. How we're getting around that, though, is that we have our MAT strategic lead. We have a post that's very much embedded in quality improvement and going out to each local area within localities, you know, going into Skye, Locale, Wester Ross, at Lochaber, to actually work with teams about what are the issues for them and look at developing plans to meet the local issues.
Thank you, Cara. Thank you, Teresa. Cara.
Thanks. I've just got 2 points. I mean, one was just more an observation. I had visited the assertive outreach team when they originally started up in Inverness, and I just thought, wow, this is so fantastic. And one of my questions was really about, you know, was there plans to expand? And that's clearly in your report about that vision. So it sounds like a really great opportunity. And I think it was probably pretty early days for them in terms of setting up that service. So it'd be really good to hear a bit more about that work that they've done and how that's expanded, you know, across Highland over time. My other question was more about a reflection in terms of some experience with adults with learning disabilities who have alcohol and substance misuse, and some of the challenges about some of those services and sort of being accessible to them. And I was just wondering about sort of the plans, and that might fit into that wider strategy that Arlene talked about earlier, but it certainly felt like a gap at points in times just in terms of that accessibility.
I suppose, Cara, I can't really, what's the word? I can't comment reasonably. I can't give a reasonable answer there, but I suppose what I would say is it's about how do we get that information? How do we pull that in and make sure as our plans evolve, both in localities, but actually how do we ensure the wavy edges are wavy enough that nobody's excluded, if that's a term that we can use, to make sure that the plans are in place. And just come back to the outreach model, you're absolutely right. It has started, it's in its early. I mean, what I love about quality improvement, we've got a model working in Caithness that's working really well. We've got models working in Inverness that's working really well. We want to take the best from everything and make sure that as we roll it out, it's the most effective outreach model for Highland.
Thank you very much, Teresa. I'm not seeing any more hands, so we'll bring this item to a conclusion. But just to thank you, Teresa, and you'll be more than welcome to come back again in 12 months' time, where I have absolutely no doubt you'll actually be offering us substantial assurance, because you'll have made the improvement that you're seeking to make. So I'll just ask committee members, are we content to receive the report, and we've discussed it, and the NHS Highland compliance with the National Alcohol and Drug Related Policy, and take moderate assurance from where we are? And I'm seeing lots of thumbs up there, so thank you very much indeed, Teresa. And please don't ever lose the enthusiasm and positivity which I can feel coming across the screen. Okay, folks. We're on the home straight. I think Rhiannon on now. We've got two items which are ostensibly looking at performance. We've got our IPQR dashboard, but we've also got our annual performance report, which is actually a report which Pam has to submit to Scottish Government. And it comes in a very prescriptive layout and what it does. So actually, as we look at these two items, although they're separate items, I want to think it would be helpful if people could think about them together. And does our annual performance reflect what we're actually reporting to committee, and vice versa? And are we actually capturing the key messages? And actually looking ahead to our development session in September, which is going to be looking at the development of IPQR and data and all that, I think if people could start thinking about that. With that, I'll hand over to Rhiannon and IPQR.
Thank you. So there's been no change in the format of the IPQR this month. So it's the same data set as you saw last time. The things I'd like to pick out, and Teresa's beaten me to it, is that she's shown the IPQR graph there on the DARS waiting times, slowly heading there towards the Scottish average. So that's a positive story, as is the ongoing reducing long waits, the over 18 week waits for CMHT, non-related to psychological therapies, and the psychological therapy waits as well. In terms of the adult social care section, I think there's maybe a very quiet positive story there in care at home. I think there's a steadying off possibly in the numbers of people who had previously been reducing in terms of receiving a care package, and a slight improvement there in the care at home related to DDs. So other than that, there isn't anything I'd like to draw your attention to on there.
Thank you very much, Rhiannon. I'm just going to throw it straight open to any comments, observations again that anyone has. I'm not seeing any hands. I would actually probably totally agree with you, Rhiannon. I think the areas of improvement are there to see, but I actually think that there's some of these ones where, and the care at home is a good example of it, we're actually getting stability into the system is actually the improvement, and it really is that in terms of how we actually begin to show that. I've noticed the read across into the. I actually think I'd picked something up on delay. Was it the delayed discharges one, which had actually shown quite a. Yes, that's what caught my eye. The North Highland delayed discharges, and I didn't know if it was something to do with maybe it is the winter showing itself again. That actually, if you look at the delayed discharges, they took quite a spike in October 2022, and then we've had the same sort of spike repeated again as we come into October, November of 2023. And I just is there something about that? Because actually looking at over the course of probably less than 12 months, we went up by 25%, and I think what we're probably seeing on the delayed discharges, and it's maybe just time for us to articulate it a bit more clearly, is actually the challenge is getting greater and greater to us. Yes. And actually the rate of increase is increasing, if that makes sense.
Yeah. There's certainly a cycle in DDs, which is an annual cycle, and it may often be related to other charts, particularly around staffing as well. But I don't know if there's anybody from the operational team who feels they can comment on that.
Joe.
Hi, so I don't actually have the graph in front of me. I can't get the thing opened, but I think in terms of the position around delayed hospital discharges, there's obviously been a significant programme of work going on for more than 12 months now, which Pam alluded to in her presentation earlier, around improving the flow and management of people within our system. But I think the reality that we've faced is that there has been a loss of capacity within North Highland of both care home beds and care at home hours, and so to some degree we've been a bit confounded in terms of the progress that we have made in some areas, and I think there's, but as Rhiannon says, there are also some interesting kind of background graphs to be looking at in terms of staffing, and particularly the use of locum and agency staff, because what we find is, although there are new processes in place where we have high use of bank and agency staff, actually getting those systems embedded takes much longer, and it's much harder for people to participate in that kind of proactive planning for discharge within the community. And I think the other thing, which the point was made earlier about the presentation of individuals, but actually we're seeing anecdotally, and now there's a growing evidence base nationally around the changing presentation of the people who are coming into our hospitals as well, in terms of their level of acuity and complexity, and that by dint of their condition they are more likely to require either increased care from what they already have, a new package of care, or indeed an alternative destination. So there are a number of factors in play, I would suggest, in that space.
I totally agree with that, Joe, and I think there's been a few things this afternoon we've spoken about which actually suggest that we're actually seeing that level, that higher level of acuity, which we saw in the acute side of things maybe 6-8 months ago, is now manifesting itself through the system, not least of which is probably one of the explanations for that massive increase in the number of scripts we're seeing in prescribing, because it makes absolute sense, doesn't it, that people once have been through the secondary care are still going to keep seeing the GPs. So I think it's actually useful now that we've got some, probably over a year of being used to these graphs now. It's actually beginning to take us away from just thinking about the absolute number to think about what it's telling us. And I think that's where we'll hopefully we will get into at the development session in September, to actually meet what can we, how will this actually help us manage, improve, and adapt our service as required. Kay, I see your hand there.
I think Simon was before me, I think, though. Did you want to come in, Simon?
I don't have Simon up on my screen there. Apologies, Simon.
Okay, thanks, Kay. Just a couple of quick points on what Joe was saying there. Firstly, you're absolutely right about there being trends within delayed hospital discharge, and we can clearly outline those. So we expect there to be a drop, for example, immediately before Christmas. We expect there to be an increase that comes in the first week of February. We expect there to be increases as pressure comes on through various summer activities that take place, and we end up with visitors, etc., etc. So that's all pretty well recorded. The problem with there are two big problems with delayed hospital discharge. First is it's a rear view mirror exercise. We're talking about what we've missed, so we're looking back, and the problem with that is that we're taking a hard number, the number of people who are experiencing a delayed hospital discharge. What it doesn't do is tell us about the number of people who didn't experience a delayed hospital discharge. Now, if we were to take the increased level of take that we've got, the increased acuity that we've got, as Joe was saying, in terms of what people are coming in with, the delayed symptomology that they're coming in with, which is resulting in slightly longer times, etc. The result is we're going faster. If you then pile on top of that the fact that we've got roughly 2,500 to 3,000 hours less of care at home, plus 160 beds formally out of the system, but actually, given that we don't have access to a number of beds as well that haven't officially closed, you could actually increase that number to well over 200 plus. bizarrely, we are more than keeping pace in terms of delayed hospital discharge, but the number is still going up. And that's because the downside of our system, if you like, the things we don't have is at such a massive level. It's almost a success that the increase is you could say as small as it is, but actually it's really big. And the reason why that sounds like a counterintuitive way to describe it is this is only going to continue to get worse because we've got a creeping situation with regard to delayed hospital discharge. So there's a couple of things have to absolutely happen. The first is we need to recognise the people that we're working with. Many of them have been with us for quite some time, so there's no sense in our planning taking place at the back end. It's got to take place much earlier, and that's a lot of the work that Joe's been doing. And then the second thing that we need to be really, really careful about is that we don't end up telling people they're waiting for a bus that's never going to come. So there's absolutely no sense in us talking to people about beds that don't exist or care hours that don't exist, because that's not going to change overnight either. It takes usually about a year for us to create an additional 1,000 hours of care at home. So take all of that into the round, Jerry, and I suppose what I would be saying to committee is there's urgent and drastic work being undertaken at the moment. On the one hand, don't be fooled by the number, because actually the system is working faster, but the challenge to the system is greater, so it looks like it's worse, if you get what I mean. And the numbers of increases in delayed hospital discharge don't actually relate to the level of challenge to the system that we've got at the moment. But that's all still wrong, because we've got people being looked after in the wrong places, so we still have to sort it. So I don't offer that as an excuse to committee. I just think you could have an entire committee on this. It's a really complex area. Bottom line is people do not get optimal experiences if they're cared for in the wrong place. And the second thing from my perspective is we need to be careful in our language about beds and about hours. So just to be clear, a hospital bed is important, but so is a care home bed. In fact, we've probably got less of them available. Similarly, the hours that we have for doctors and nurses are really important, but actually care hours are even scarcer than we have in that. And until we start thinking in those kind of terms, we're going to suffer with trying to allocate things that don't exist.
Thank you, Simon. Thank you, Simon. Kay?
I just, when people were talking, I just wondered if there was any correlation between what I was saying earlier about when people are reaching the mileage rates and dropping to the 25p, to if there's a time of year when people care at home workers are leaving the service. I didn't know, I don't know if that's the case, but just anecdotally yesterday, getting 2 phone calls about people who were worried about the mileage rates. If people are coming over to the service from a private provider or something like that, member of staff, then private providers don't have the mileage. They usually are in a centre of a town, so that worker wouldn't have had a mileage issue really, because they would be on centralised people, because the way it works is usually the more cheaper options are done by the private providers. So if the member of staff was coming over from that provider, and then the realization that they're doing a lot of mileage, and they've still got till April till their mileage goes back up again. I don't know. I just thought I'd throw that out again, because it seems weird that it's October that there's a spike.
I think we will ask the question, Kay. I suspect no one will be able to answer it, but I think it's a very interesting question. It's a very interesting question. We will ask it, but whether we'll have an answer or not, I don't know. Joe, have you had your hand up and it's now went down? Is that?
Just in the interest of time, it was only to say that some of the data that we do have is about our average length of stay, and actually in Highland our average length of stay is well below the Scottish average. So yeah. To Simon's point about the fact that actually we are doing things faster, which is mitigating some of the potential increase that we would be seeing, but his point was well made around anybody in delay is too many.
Yeah, I think it's a really important point that Simon makes. We should not lose sight of the fact that we've probably flattened that curve quite a lot. but even the fact that it exists is not a place we want to be. But no, thank you very much for that, everyone. So we're been asked to consider and review the framework, but it's not changed, and to accept moderate assurance and recognise the continued stressors facing both the NHS and the care services. Are we happy to do that? Thank you very much, everyone. And I know Joanne at the last meeting identified some areas which she would like to see incorporated in future reports. So I think we'll make sure we pick those up at the development session, Joanne. So we've got the Highland Health and Social Care Partnership Annual Performance Report. Pam, do you want to say a few words, or is it substantially here for noting before it's goes to the, I think it's going to the board again at the next board meeting?
It's here for noting, and I've referenced it earlier in my presentation. A really important document for us to measure us against the health and wellbeing outcomes, to showcase some of the work, to discuss some of our challenges, to discuss some of our journey. So to have a bit of a look back to last year and then moving forward to this year, so that we start to get into that iterative way of using the health and wellbeing outcomes to demonstrate those outcomes for the public. So this is a document for the public. So a really important document to have it. Rhiannon has led on the work, so I'm happy for Rhiannon to give us a frame on some of the key aspects in the report. It's got nice pictures in it. It's got good outcomes in it. It tells us areas where we need to focus on. It helps us think about how we do our outcomes focused commissioning of services going forward. So really important. Pleased to bring it to the committee for noting, and it's evidence-based from all of the information that we have. And it'll go out to be published. It'll go to the NHS board meeting, and then it'll go out to be published at the same time as our Highland Butte. They're much further down the road in terms of they've published their annual performance reports yearly for some time, and they really have that envious iterative process of being able to look back and look forward and learn and shape and change, and a really pivotal document for engaging with the public and demonstrating that effectiveness and getting that feedback built in so that we can share that back with our public and communities. So I'm happy for it to be noted. It's offered with substantial assurance because it's following the national framework guidelines for publishing it. So it's the first time that we've come into line with those documents. So really pleased to get it to this stage with thanks to Rhiannon and her team and senior leadership team colleagues in the partnership to offer up the examples and the narrative to get it to this place. So I'm happy if Rhiannon wants to come in and add anything or quickly highlight any areas of the report. Thanks, Rhiannon, for your input. It's been much appreciated. Thank you.
Thank you. So I suppose from my perspective, it's been what I've been trying to do is to get together a report that's easy to read for public consumption, but also makes sense to us as an organisation, a board and a committee. So I've tried to incorporate the IPQ, the familiar IPQR graphs in the performance narrative. Also pull out some of the key achievements that which the teams themselves have come up with, and so it's not just all about the numbers, but it's about the narrative that you wouldn't see normally in a data report. And then in the appendices themselves, you'll notice that we've had an attempt at pulling together cross-referencing both the health and wellbeing outcomes and the strategic ministerial outcomes as are required. They are what the government requires us to publish, our performance against those, but also how they map against the TWC, the Together We Care outcomes. So once you've all read it, if you have any comments on that format and whether it makes sense or not, that would be really helpful. That was more for us probably than the public in those appendices, but then the narrative would be more for the public understanding. So hopefully I've pulled it all together and tried to make that something that means something to everybody. It is still in draft form, it's still open to comment, and I can see just reading it through today, there are a few things I need to change, and typos and in the flow. So thank you.
Thank you very much, Pam and Rhiannon. I've had a quick read of it. I will be honest, I've not read it in great depth yet, but I think you've achieved your objective of a readable document, and I certainly recognised the graphs, and I recognised the story that we were telling in there, and I thought it was important that we highlighted a lot of those achievements which we've had in the year. It's often very easy to forget about all the good stuff that we've actually achieved in the year, and I think the read across from the Together We Care and the National Performance Framework is actually is fundamental, and it's one of the things I do want to talk about. And if I keep talking about this development session, the 20th of September, but that is ultimately how we are measured as a partnership. So I think if people could think about that, I think again, just conscious of time, if people have got any questions or comments, they want to just feed them directly into Rhiannon, and she'll no doubt she will answer the questions and make any changes that are required. But a great thank to both Pam and Rhiannon for actually, I think, getting us our first. I think we could realistically call it our first go at this, and it's a good first go, and we'll get better as we move on. So thank you to you both.
Perfect.
Okay. Item 5 on the agenda will take us hopefully about 30 seconds. We've got the work plan there for you to note, and I've already taken a note of a couple of things which we need to add on to the future work plans, and I will sit down with Pam and maybe a few other colleagues, because I think we have to try and squeeze it a little bit, because really we've had 3.5 hours here this afternoon, and it's been a long 3.5 hours, and I'm not sure we can. We get the full value when we get to that stage, as well as the pressure we're putting on report authors as well when we've got such a large agenda. So we will pick that up moving forward. I can't promise any changes possibly until next year, because we've got an assurance programme which we need to deliver against for this year. The committee terms of reference are attached there. Amazingly enough, we're at that time of year where we need to review our terms of reference in order that we can make any amendments that we wish to do so. What I will actually just say is, if people could just read the terms of reference, and if you've got any changes or amendments you'd like to make, just email myself and I'll pull them together, and at our November meeting we'll have a document which will just highlight any changes, and then we can feed those into the audit committee just after Christmas for a subsequent transmission to the board in March of 2024, and then before you know it, we're talking about next summer and talking our lives away far too quickly. So thank you very much for your perseverance this afternoon. I shall quickly say, any other business does anyone have, or we had enough for the afternoon? I know we've all enjoyed it. It's been a great meeting, but it's just a little bit too long. And we will work. Pam and I will work on that. So thank you very much, everyone. Thank you for all your contributions. It's been really good. Thank you very much, and thank Pam, if you could pass our thanks on to all the authors and presenters today. Thank you very much, everyone, and I'll see you at the development session on the 20th of September. Bye bye.
Okay, take care.
Bye.
Bye.
Thanks. Bye.
Thanks, Jenny. Thanks.
Bye.